Oh, good afternoon, everyone. I'm going to first maybe start sharing a little story that I have. It happened about 4 years ago. I was actually admitted and I needed to receive cytotoxic medication. I'll just keep it like that. And I had to receive this in both an outpatient setting and an inpatient setting. Throughout my experience, I noticed the nurses were how they put on their PPE was quite variable. And there was one nurse in particular who I was sitting in my bed. This is when I was admitted, watching Stranger Things. She comes into the room and she's about to give me my medication. And she's reaching into the bag, has absolutely no PPE on except one glove. She reaches into a bag that is clearly labeled cytotoxic, grabs the medication with her one gloved hand, and then it kind of makes me stop and I start thinking. And I started telling her, I was like, that's maybe not what we're supposed to be doing. Usually you're supposed to be wearing a mask, face shield, a gown, maybe chemo gloves. Those are the things you're supposed to be wearing. And then my husband comes up to me and he's like, you're a little judgmental. I was like, I'm not surprised. So then it made me start reflecting on my own practice. And I realized when I used to give chemo, it also wasn't that great. There would be times where I'd be rushing in and out of the room. I would be touching my coworkers' pens with gloves that I just used to hang my chemo. My face shield would be half on, half off, and my gown was definitely half off. So this is what made me kind of think of my presentation today. We really learn these lessons through near misses, through habits that we've carried by watching others. And we kind of just say, this is how we've always done it. And this is exactly the reason why I think it's important to have a conversation about occupational safety around these hazardous medications. So, good afternoon, everyone, again. As oncology nurses and healthcare professionals, many of us administer hazardous medications, and it becomes really part of our routine process and it feels quite normalized. But the literature consistently reminds us that these medications are among the most toxic handled in healthcare. So today's presentation is going to be grounded in the literature, and I'm going to attempt to connect the science to frontline nursing realities because many of these risks really are carried out in our day-to-day activities. Today's presentation will focus on occupational safety in anti-neoplastic drug administration, and this really is an issue that's deeply relevant to anyone who's working in oncology. Healthcare professionals spend a great deal of time around patient safety, treatment efficacies, and cancer outcomes, as you guys heard from many of the presentations today. But today, I really want to shift towards ourselves, the healthcare workers who prepare, transport, administer, clean, and dispose of these medications every day. So, at the end of the session, I hope that the participants will be able to describe occupational risks, recognize the consequences, both acute and long term, apply evidence based guidelines, identify barriers to adherence, because, like you guys heard in my opening story, there's quite a few of them, and really promote a culture of safety. So again, throughout this presentations, I really do encourage you guys to reflect on your own practice and look at the environments that you guys are currently in and try to see different ways that you can improve. So let's begin by first understanding the risks. Going to start with a quiz question. If you guys want to take out your phones. There's quite a few of these, so it's kind of worth joining in if you can. Give everyone a couple more minutes. Oh, is that the question? Well, welcome everyone. That's not the question that I had, but I'm glad that you guys are all joining in. So I'm going to start with the first question, which is a fact or fiction. Healthcare workers handling hazardous drugs have shown measurable contaminations in urine samples in studies. Give everyone a couple seconds. Alrighty. So a little bit mixed, but the answer is in fact. So let me just go back to that. Multiple biomonitoring studies have identified traces of antineoplastic drugs or their metabolites in workers' biological samples, so those can either be hair or urine. A systematic review done by Lesso and colleagues found measurable contamination among healthcare workers across multiple settings, and especially with nurses who are directly involved in handling these hazardous drugs. So some studies even identified contamination in personnel that are not directly administering chemotherapy, and this really shows that there's a widespread contamination. So again, occupational exposure is not theoretical, it's actually measurable. As explained in many of the presentations today, chemotherapy is really kind of that double-edged sword. It's designed, and I felt, Anna, you really hit the, hit the mark. It's really designed to target rapidly dividing cells. Unfortunately, it doesn't differentiate between cancerous cells and also healthy dividing cells. So these medications work through mechanisms of action like DNA damage, inhibition of cell replication, blocking mitosis, and interfering with cellular metabolism. Researchers estimate that there's going to be over 250,000 new diagnoses of cancer in Canada, with about 87,000 deaths in 2026. So as you guys can see, there's a huge rise in cases. Therefore, the risks of exposure are also increasing. The other thing that's important to note is that now we are using these anti-neoplastic drugs for things that are not, for diagnoses that are benign, therefore increasing our risks even more. So, and as you guys, of course, heard throughout the presentation today, there's toxic effects that are well known in our patients, like myelosuppression, alopecia, mucositis, infertility, and secondary malignancies. So this is why the NEOSH classifies these drugs as hazardous. And for those of you guys who don't know, the NEOSH is the National Institute for Occupation Safety and Health. I'm actually going to be bringing them up quite a few times in the presentation, so it's a good acronym to know. I want to maybe start by going back in time to the 1940s, an era I really like the most, and and between the 1940s and 1960s, that's when the focus really was on patient toxicities. They noticed in the 1970s, however, that there was more evidence that healthcare workers handling chemotherapy were also being exposed. One of the landmark findings frequently cited in the literature was detection of mutagenic activity in urine of oncology nurses handling chemotherapy agents, and I believe that was published in the Lancet in 1979, which leads us to the 1980s. A really good decade again, and where initial PPE recommendations and safe handling guidelines emerged. In the 1990s, more evidence was linked towards occupational exposure to reproductive risks and genetic damage. And then one of the major milestones occurred in 2004 when NEOSH released comprehensive safe handling recommendations. Now, more recently, there's been a shift towards workplace culture, PPE adherence, and really system level safety initiatives. And again, despite having decades and decades and decades of guidelines and studies, the studies continue to show ongoing contamination and inconsistent adherence to protective measures. It's going to lead me to my next quiz question, fact or fiction. Is oral chemotherapy safer? More specifically, is handling oral chemotherapy safer? So you guys got it right. The answer is fiction. Studies emphasize that oral agents can be handled with the same caution as intravenous chemotherapy. Um, it is important to note or I want to say the sequence and how we handle these oral medications is actually quite important to help reduce exposure. They really do suggest if ever a patient is on multiple medications to start with the less hazardous and end with the more hazardous so that there isn't that cross contamination as we're administering and well preparing and administering. So um, the exposure risks can exist really across the whole medication use process, from anything like preparation to even 48 to 72 hours after administration. Nurses are involved in the administration, line management, discontinuation, spill management, and indirect patient care, which provides us many opportunities for exposure during our routine workflow activities. And it's not only during these kind of major events like spill events. You guys can see here really a different list of other professionals who are involved. So it's not only nursing and pharmacy. There's other people like housekeeping who also have an exposure risk and transport and waste management. So why are nurses actually at higher risk? Researchers consistently identify nurses being the highest risk group because they have frequent direct contact with these hazardous medications. They also have prolonged exposure opportunities, prolonged time at bedside, exposure to patients' bodily fluids. They also deal with line management, so line disconnection and tubing management, and then um, they ultimately intimately take care of any spills. So why are these drugs so hazardous? Hazardous drug medications that pose a risk to healthcare workers because they have such properties like they are carcinogenic, teratogenic, they have effects on DNA. They can be organ toxic to vital organs like your liver and your kidneys, and they also are known to be toxic to your reproduction. So they're associated with infertility, miscarriage, and reproductive harm. So the National Toxicology Program uh, further reinforces this evidence in saying that a lot of these medications were related to spontaneous abortions, chromosomal abnormalities, and DNA damage among exposed personnel. You can see here the IARC, or the International Agency for Research on Cancer, classifies many chemotherapy agents as known or probable carcinogens. So you can see here they're kind of grouped from group 1 to group 4. Group 1 is known to be carcinogenic to humans. Group 2 is probably 2A, sorry, is probably carcinogenic to humans with limited evidence in humans but sufficient evidence in animals. And then 2B is carcinogenic to humans with limited evidence in both humans and in animals, which reinforces the idea that safe handling is essential and not optional. You can see on the left-hand side, sorry, the right-hand side. For those of you guys don't know me, I actually don't know my left from my right. It's a weird thing of mine. You can see here a list of common medications that are given in infusion centers quite often. For example, is cyclophosphamide. It's known to be carcinogenic, or the effects on healthcare workers are that it's carcinogenic, it has reproductive toxicity, can cause infertility, miscarriage, and also DNA damage. If you look lower down, a medication, for example, like 5-FU, can cause skin irritation, iron irritation, and reproductive side effects. So now we're going to look a little bit more at exposure, which leads me to my next question. What is the established safe level of occupational exposure to cytotoxic drugs for healthcare workers? All right. Okay, you guys got most of you guys got it right. Although I stumped quite a few of you. So there is no known safe level of exposure. Again, the NIOSH emphasizes that many hazardous drugs are carcinogenic and genotoxic, meaning that low levels of repeated exposure may carry a risk. Going to do this one pretty quickly because I believe I answered it myself earlier. So only nurses and pharmacy preparing staff preparing chemotherapy are at risk of exposure. Fiction. Good job. So again, exposure can extend to housekeeping, waste management, transport, caregivers, laundry personnel, and anyone really entering the contaminated environment. The next one, surface contamination with hazardous drugs, have been found in areas where chemotherapy was not administered. Alrighty, so fact. Good job. Environmental contamination studies have identified hazardous drug residue on multiple services, both in and outside of oncology units. These studies identified contamination on floors, IV pumps, keyboards, mouses, phones, cell phones, patient bathrooms, and nursing stations. So, where and how does this exposure happen? Exposure happens really through multiple routes. The literature emphasizes that the dermal route is the most common pathway for exposure, and it's often done through repeated contact of contaminated surfaces like tubing, pumps, medication bags, and patient care equipment. So, high risk activities include priming tubing, disconnecting tubing, cleaning the spills, and handling bodily fluids. Like I mentioned before, a lot of it can happen through dermal exposure. It can also happen through accidental needle stick injuries. The other points where exposure can happen are through inhalation. A lot of that is more when, or I'll say more for pharmacy when they're actually preparing the medication. Accidental spills that can occur from broken vials, disconnected tubing, and improper waste management. And then through mucous membranes and ingestion, like your eyes, nose, mouth, and accidental hand to mouth transfers. So studies have detected chemotherapy residue again in areas beyond the oncology suite, which really tells us two things. Contamination is actually quite difficult to eliminate. And second is that consistent protective practices remain essential and in highly specialized oncology areas. There also have been studies that have shown that contamination was found on found on gowns, uniform, linen, and on patient care equipment, and that again, it's not limited to medication administration areas. The thing that's also important is there was a study that actually noted that frontline workers carried contaminated clothing home, which then increases the risk of actually carrying this contamination to family members and anyone else in your household. So again, looking at kind of all of the other ways that we can get exposed through handling bodily fluids like urine, stool, vomit, and sweat. The medication, depending on the half-life, can still remain hazardous for 48 to 72 hours after treatment. So it's really important that we continue these practices long after that the medication has been administered. The other thing that's important to note, specifically with vomit, is any patient that is on oral chemotherapy, if they are at risk of vomiting, it's really important that you are wearing your face shield when administering. And one of the other bodily fluids that often gets forgotten is sweat, but it has been known to um, carry hazardous waste. So, what are the long-term and short-term consequences? So, more acute short-term consequences are things like headache, dizziness, nausea, vomiting, skin irritation, eye irritation, and hair loss. And then the more long-term consequences, similar to those of patients, is reproductive harm, miscarriage, infertility, congenital abnormalities, DNA damage, chromosomal abnormalities, and an increased risk of leukemia and secondary cancers. And this is why I want to say prevention is incredibly crucial. To go back to oral chemotherapy, exposure really happens in, or more risky exposure happens in these situations. So if you're either cutting, splitting, administering, or disposing of the medication, it is incredibly important that you are using the appropriate PPEs and safe handling protocols. So, like it was previously mentioned, there is a zero threshold. There is no known safe level of exposure to these medications. And again, the idea is that we're constantly in these environments, so it's really a cumulative harm. So, long-term effects can happen from this repeated exposure. So if we look now at best practices, there are different best practices and guidelines that came out. Here's a list. I mean, this is a list of three of them. So the ONS released a toolkit that emphasizes that safe handling requires more than education alone. It requires engineering controls, PPE, consistent competency reinforcement, and institutional supports. And there was also another major milestone, although I'll say this is primarily in the United States, which is the USP 800, because it operationalizes many longstanding recommendations into enforceable standards in many jurisdictions. So minimizing the exposure is really the core principle. Polovich actually says that minimizing occupational exposure is not merely a regulatory obligation. It's actually a moral imperative for every institution that asks their staff to handle hazardous drugs. So, how do we do that? We do that by reducing contact through systems like closed system drug transfer devices. For those who are preparing these medications, we want to prevent inhalation through, again, these other engineering controls like a biological safety cabinet or compound isolator. You want to reduce or eliminate the ingestion risks. So we really try our best to say no eating, no drinking, or no applying cosmetics like lipstick in drug preparation or administration areas. And again, it's really this idea that we have an ongoing commitment to these safe practices. It is really important that we take a multi-dimensional approach. Um, there's no single intervention that's going to be sufficient. We really want effective protection, so that requires an organizational commitment, appropriate equipment, consistent PPE use, competency-based education, clear policies, accessible spill kits, adequate staffing, and ongoing monitoring. So really, safety is the strongest when it's worked in a system and not only with one individual behavior. So like every other presentation, there's always a theoretical framework behind things. So this model is based on the health belief model. And it suggests that nurses understand the hazards and feel confident using PPEs properly. Sorry, when nurses understand the hazards, they feel confident in using PPE properly and they perceive fewer barriers to safe handling. Really, what this is actually also saying is that interpersonal influences matter. So seeing your colleagues, preceptors, educators, and leaders really shapes what's considered normalized practice in our environments. And the model also recognizes that conflict and competing priorities can also have a direct effect on adherence. So next, let's talk about PPEs. So in a NEO survey by Biano and colleagues, a substantial proportion of respondents reported inconsistent use of gowns and chemotherapy gloves, One finding that was actually quite concerning was the belief that PPEs were unnecessary because they felt that exposure risk was minimal to skin. So, despite the evidence of repeated, re, despite the evidence that repeated exposures over time actually carry a risk. So one other study also identified that during these kind of more major moments like spills, PPE were still remained suboptimal. So you can see here, gloves are probably the things that are most commonly used. Gowns are still used quite inconsistently. Eye protection is uncommon, and respiratory protection remains quite rare. So another question for you guys. Which measure is considered the most effective at reducing hazardous drug exposure? You can either have double chemotherapy gloves, staff training and education, closed system controls, or careful handling by experienced staff. Okay, so we got a little bit of a mix. Do you guys want to know what the answer is? It is biological safety cabinets and closed system controls. Oh, there's a leaderboard. Okay. So the hierarchy of controls is actually a foundational occupational health safety principle that is repeatedly emphasized in the literature. It tells us that eliminating and reducing hazards is really a system level approach, and we don't solely want to rely on an individual's behavior. So I'm going to be going through kind of all of the different levels. You can see here that the number one ideally is elimination fully. Of course, we are all working in oncology, so it's going to be kind of hard to not be exposed. But then the second level is engineering controls, administrative controls, safe work practices, and it is only the PPE is our last level of defense. So, what PPEs, and I'm sure you guys are all very well aware of them. You're looking at chemotherapy gowns, double gloving with chemotherapy, and you're wanting to make sure that you're changing the outer layer every 30 minutes, eye protection and respiratory protection when aerosol risks are present. And PPE must be properly selected, available, and consistently used properly. So, why does double gloving matter? Double gloving reduces permeation risks and provides additional protection and barrier more than one glove in case that one glove becomes contaminated or damaged. And guidelines consistently recommend double gloving when handling hazardous medications. Um, so again, it's important. There's also gown safety standards. Not all gowns are quote unquote created equal. Chemotherapy gowns must be disposable, lint-free, have low permeability. They must be closed in the back, and they have tight cuffs to avoid runoff onto the hands. Uh, And then, of course, everything around spills. Of course, spills happen. We're only human. And um, it's really important to highlight that we need to make sure that there's spill kits that are readily available. I also do want to mention another thing that's quite important that I want to say is probably not integrated in practice as much is that we are doing simulations and trainings when it comes to spill kits. I remember the first time I had a spill, somebody said, go get the spill kit, didn't know where it was, found it, had no idea what was in it, opened it. And then, as you guys know, as I'm trying to work through all of those different steps, I'm realizing I'm just constantly getting exposed to this liquid on the floor. It's also important to have a clear response procedure and, again, the idea of ongoing competency assessments. So, workplace culture is also a huge influence on safety behaviors. Researchers show that you're more likely to handle these medications safely when you prioritize safety, when you have leadership support, when you encourage reporting, you have adequate staffing, and you normalize the use of PPE. So a strong safety climate makes these practices a lot easier and a lot more sustainable. So again, we really want to make sure that PPEs are actually accessible and they're not in a corner somewhere. You want to make sure that the leaders are modeling safety, so they're consistently wearing your PPEs, and that safety is prioritized. So things like time pressure and staffing gaps do not override these safety priorities. How do we improve PPE compliance? Studies demonstrate that compliance is improved when organizations have staff champions, so peer advocates that model these behaviors and hold their colleagues accountable. Peer auditing, so again, this idea that there's a non-punitive observation that really normalizes and identifies any of the gaps in our practice. Targeted education, so just-in-time training, often actually outperforms our annual modules, which we're all quite used to, and really timely feedback. So if you were like me, the patient in the bed, it was important that you, as soon as you see that there's a gap in the care, that you automatically tell the person. So if they're wearing their gown half off right away, because that actually corrects the behavior a lot better. And then again, leadership support. So this visible commitment by leaders to be able to sustain momentum. And then the last, again, well, not last, last was elimination, but in the hierarchy, it's this idea of engineering control. So there's a lot more research now on how do we kind of force functions to reduce the risk of exposure. And this can be done through kind of closed system devices, biological safety cabinets, having things like spill kits, and having things in place like negative pressure rooms. So again, this is why multi layers of protections really do remain necessary. So the next is barriers to adherence, and this, oh, yeah, yeah, okay. What this was supposed to do, so I'm just gonna, it was supposed to go to a word cloud, so I'm just gonna kind of scream it out loud, have you guys scream it out loud. What would you guys say are barriers to PPE use? Time. Anything else? It's true. It's true. Back orders, training, disbelief. That was actually a huge one. Knowledge. I think those are all good. So, as you guys mentioned, the number one is really time pressure. So, high patient volumes and workplace demands often lead to shortcuts. Other things that directly affect or that are direct barriers are this idea of discomfort. So, heat, restricted movement, and poor fit compliance. Lack of awareness that was brought up with knowledge. So, understanding the risk and not recognizing the different exposure pathways, and limited supplies. So, limited supplies for correctly sized and rated PPEs. So another thing, and I mentioned this a little bit before in the slide, but when staff feel rushed, unsupported, and understaffed, that's when they actually notice that adherence really did decline. So of course, it's important that we create these safety environments to really support um, the notion of having good precautions. The other thing that was found in literature, so recent colleagues introduced another important nursing consideration, and that's the idea of ergonomics. So healthcare workers reported physical fatigue, repeated strain, awkward postures, and discomfort associated with long-term PPE use. For those of you guys who ever worked at the old Royal Vic, wearing a bunch of PPEs with absolutely no air conditioning in 40 degrees was just really not comfortable. And then really the last section is workplace culture. Again, education is important, but it's not enough to adequately change behavior. Literature consistently shows that safe practices emerges when education and leadership support accessible PPEs, workflow integration, reinforcement strategies, and psychological safety are all within the organization. So healthcare workers cannot consistently practice safely in unsafe systems. So what can leaders do? Leaders must ensure, again, that PPE access is available and appropriate. They must support staff training, invest in engineering controls, address workload concerns, support reporting systems, and really promote psychological safety. And then what can we do today as nurses? We want to be able to make sure that we're wearing the recommended PPE. We want to be able to speak up whenever there is unsafe conditions or unsafe practices, report spills and exposures, and really support our colleagues, especially, I want to say, like that new nurse in the first story that I had who did not wear any of her PPEs. It's important to support those people in their practices to make sure that we're protecting not only the patient, but ourselves and our loved ones. So the takeaway again today is we would never knowingly expose our patients to unsafe chemotherapy practices. So why would we accept unsafe exposure for healthcare workers?